Okay, so we'll be switching gears a little bit in terms of scale of what we're looking at. I also wanted to just say that my co-presenter Stoddard wasn't able to make it. He has the flu. But our role in our job is largely to be able to provide data to different organizations looking to use data to tell a story around the value of an intervention, highlight public health challenges. And this has been a project that Stoddard and I have worked on throughout the last couple of years as we've had time. It's been a sort of side passion project of ours, and I'm excited to be able to share it with you. There's a lot of data in here, and it's a very small subset of what we plan to publish in a report in the coming months. And so if you see things within the data that I'm showing you, I would love to discuss more. There's a lot there, and I think a lot of insights that can be gleaned. All right. So from a show of hands, before I get into the background here, how many people are familiar with ICD-10 SDOH Z codes? All right, great. So I don't have to go into too much detail but they're diagnostic codes that were meant to codify social determinants of health or health-related social needs and administrative claims data. I think throughout the last couple of days of this conference, we've heard ways in which these Z codes have been used, ways in which we may need to think about whether we should be using them or not. And I'm excited to hear from other speakers in this panel about the direction in the coming months and years around how we might use these. The codes are a Z55 through Z65, which is why we call them Z codes. It's an aside. But why we might want to code for social determinants in health and what was at the root of integrating these into administrative claims is being able to use this data to design and implement interventions and policies to address social determinants of health, things like measuring quality improvement or looking at changes over time longitudinally with patients, enabling providers to make clinical decisions that meet an individual's need. If you're documenting it in your EHR or in this claim, you're able to understand how that diagnosis might inform decisions that you're making. Because we're talking about administrative claims, it's also widely intended to be a mechanism to reimburse providers for social determinants of health-related services. I will say that just broadly, I'm not seeing that actually be used as often for reimbursement. There are lots of other ways that payment is happening, but using it on a claim in this direct way is not widely adopted. And if we're able to use social determinants of health coding on claims, it would improve our capacity to do analytic and research. Administrative claims offer an interesting opportunity to think about individual needs versus population level, and you're able to do both with this type of data. Again, there can be limitations to how we want to do that, and think through what it means to collect this data as well. There's been a lot of existing research done that has tried to quantify the use of these Z codes in claims. A lot of it's been limited to single years or geographic areas or insurance markets or places like points of service. The theme coming out of all of these is adoption has been really low. You're not seeing high levels of adoption of using these codes in administrative claims. The spoiler alert is we found the same thing. But I think also, as you've been attending sessions throughout this conference, you've probably heard about all the things that have to happen to get to the point in which we would even be documenting a Z code in a claim. There needs to be a shared understanding of the screening process and the conversation. You have to have a successful screening process in which you're able to engage with the patient. They have to trust you enough to share that information and have it be a valid response. You might have to have a system in your EHR to be able to capture that. And then you would have to either have a provider or a medical coder understand, either through notes or through other documentation or through the Z code itself, like, can I actually put this on a claim? So it's a long process. So the idea that it's low is not surprising. There are also incentives to systematically screen for and document social determinants of health in a claim. And those can vary by insurance market and state. I think we've heard a lot about 1115 waivers. The North Carolina Healthy Opportunities pilot has been, looking to do that at a state level. We also have a lot of CMMI demonstrations, such as accountable health communities that targeted screening for Medicare and Medicaid patients. Until recently, Medicare Advantage had the value-based insurance design program that will be sunsetting this year, but plans were incentivized to include health-related social needs benefits. There are CMS quality measures. Who knows? Again, I feel like everyone is caveating this. Who knows what will continue to exist moving forward? We all did this research and prior to January, but I think that there are incentives, and we're also seeing in the commercial market, which does not have policy incentives or federal mandates to do certain things. We're still seeing within the ACA marketplace or other private employer-based insurance, we're seeing people have plans incentivize offering these types of benefits or offering payment for different types of interventions or to help manage risk in populations, largely in part to be competitive in that market and to recognize the evidence that these things can help improve people's health. So the study aim here was to describe how the documentation of social determinants of health through Z codes has varied over time: geography, payer type, place of service, provider specialty. We also have demographic information and can look at many of these things sort of by one another. And like I said, we'll be looking at a subset of these. Actually, I want to also make a point that I say documentation of Z codes here rather than often when we talk about using diagnostic codes and administrative claims, it's to quantify the prevalence of a condition. And I think at this point, what we're able to do here at the scale that we're doing it is to talk about how frequently these are being used rather than really talking about true prevalence in a population. Okay. So the methods that we used, Milliman has a data use agreement with CMS, so we used the Medicare 100% research identifiable files and Medicaid TMSIS data, and this covers 100% of Medicare, Medicaid, and CHIP beneficiaries in the US. Medicaid varies, sort of quality can vary state to state, so we excluded long-term care claims for Medicaid because of some quality concerns in the data itself. It doesn't exclude people who receive long-term care, just the claims generated for long-term care services. And then we also have a proprietary commercial claims data set that is fully de-identified, and it contains claims and enrollment records for over 100 million lives. So there's a lot of coverage in the US of insured individuals. The study did not include an exploration of uninsured individuals because, again, we're looking at claims data, which is generated through insurance. So we summarize the percent of claims, members, and providers with at least one Z code on a claim by all of the dimensions I've already described. And we looked at these for 2016 through 2022, so we could also look at over time how things changed. And then for 2022, we were able to dive into a little bit more detail around the types of dimensions we were looking at, largely in part that it's really computationally heavy to look across 100% of Medicare and Medicaid, and we're limited in some ways there. The last methodological piece here is that we tended to summarize both just did you have a Z code, but also which type of category of Z code did you have appeared on the claim. Generally, we stuck with using the 3-digit Z code, which for each of these rows, there are many codes under them. The one exception to this is that we broke out Z59 into a couple of other categories because it really lumped together many of the sort of 5 standard domains of health-related social needs or social determinants of health screening that are being conducted in clinical settings. So we wanted to be able to look at those in particular. And the other thing that I'll highlight is we have a lot of categories that are related to things like related to relationships in some way, either through your upbringing and experiences there, through having strain or social discord among friendships or family relationships. And there are specific sort of codes for all of those as well. All right, now is the part where I see how much time I have to actually talk about this data. So the first thing we did is look at prevalence over time. All of the charts that you'll see in the following slides follow the same format: commercial, Medicaid, Medicare Advantage, and Medicare fee-for-service. Medicare Advantage and Medicare fee-for-service got split out in part because they have different incentives. And one is driven, Medicare Advantage is driven by private health insurance, and Medicare fee-for-service is federally provided. We have data, we're displaying data for 2016 through 2022 for the commercial, and we just have 2021 and 22 shown here for the public insurance. Again, in part, we're rerunning some things, and it's taking far longer than I wanted to. In general, though, based on other research that we've seen, we're seeing an increase over time from 2016 through 2022. Prevalence in the commercial market by members, which is the blue line, is around 1% by 2022, so it's about doubled since 2016. Members in Medicaid and Medicare fee-for-service are at about 1.8% of members having a Z code in 2022, and it's increased slightly for both of those from 2021, and then Medicare Advantage is at 3.5%, so much higher prevalence or documentation happening in Medicare Advantage. We also show providers who are documenting as well, and I'll get to some more detailed provider information in a little bit here. We also show percent of members with at least one claim with a Z code by state and market, so you can look at the geographic variation. Again, I would love to talk to others after this session if you work with a specific state or a specific, are working with a specific population, to talk about what you're seeing here, and especially for Medicaid, where like every state does different things. It would be great to talk about how health-related social needs have been implemented and addressed through your Medicaid program. But here again, we see commercial just relatively low. A darker blue color means closer to 0. Lighter colors, we're getting close to the max of 6% of members with a Z code on the claim. And we see a lot of variation in Medicare Advantage and Medicaid, little less in Medicare fee-for-service. Okay, so I think this one is going to be of a lot of interest here. So in looking at those 3-digit zip codes, or these larger, sort of higher level categories of types of Z codes, we look to see percent of members with each Z code by each of these categories. And so the scale here is 0% to 1.2% of members. And then we have Medicaid is dark blue, Medicare Advantage is yellow. Commercial is light blue, and Medicare fee-for-service is green. The key takeaways here are that in general, we're seeing a much higher prevalence of the sort of relationship-based types of Z codes than we are seeing in some of the types of social determinants of health that we typically talk about in terms of interventions. With the exception of housing, which has a pretty high prevalence across all of the public insurance, which I found really interesting. And I think we're seeing pretty low documentation for things like other economic circumstance or poverty. Both of these include things like access to utilities. I think there's transportation, financial instability, and we are interestingly still seeing sort of across all lines of, all of these categories for the most part are being documented across all markets. All right, I got 3 minutes. So I'll just talk about this one and then I'll go to conclusions. So here is actually percent of providers by place of service that documented at least one code. So it's saying at a place of service, how many of those providers who are working there are actually documenting at least one Z code. The theme here across all of the different insurance types is that we're seeing a higher prevalence of physicians or other providers documenting in behavioral health related places of service, things like community mental health centers, inpatient psychiatric facilities. We have, those are the two, federally, no. And then we also have some telehealth related, high prevalence of telehealth related places of service, and things like emergency rooms and rural health clinics, as well as federally qualified health centers. We see similar things by specialty, in which we're seeing behavioral health related specialists. Higher percentage of those providers are documenting Z codes. And then the key takeaways from the study here, as I talked about, prevalence in claims is not equal true prevalence in the population. And we're, seeing low adoption, a rate of low adoption still. And there continues to potentially, be potential for large-scale analytic or research purposes, but we would need to increase adoption first. I think we're at a point where there needs to be decisions around what that looks like and what we want, what will be appropriate and how to use those. And then I think the last thing is with the note of, a lot of social determinants of health, Z codes that are being documented being related to behavioral health environments and topics related to behavioral health, such as relationships. There might be something we can learn about how those types of Z codes are being used in those settings, why providers are documenting, and what sort of allows for them to capture that information. So thank you.